Good evening, everyone. I welcome you all to the webinar on PARP inhibitors in epithelial ovarian cancer, organized by the International Association of Oncology and our supporting partner, BioLeaks. On behalf of the International Association of Oncology, I would like to extend a warm welcome to our esteemed speakers and participants who have joined the forum today. I can assure you that this session will be very informative to all the participants who have joined us today. I would like to give a little brief about the International Association of Oncology. International Association of Oncology is one of the renowned professional associations of medical oncology and life science professionals. IAO is a non-profitable professional association meant for research and development in the field of medical oncology and life science. IAO is an international forum for researchers, academicians, doctors, and practitioners for sharing knowledge and innovation in the field of healthcare and life sciences. IAO aims to bring together worldwide researchers and professionals, encourage intellectual development, and providing opportunities for networking and collaboration. A little bit about BioLeaks. BioLeaks Worldwide is a not-for-profit professional association which prominently promotes research and development. We at BioLeaks have brought a revolution in the field of worldwide conference. BioLeaks Worldwide brings together the professional wizards and leaders who have explored all avenues to reinforce the field of life sciences and medicine technology. BioLeaks Worldwide conducts events globally which help in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians to improve and progress over the world through worldwide conferences with the speed of science and technology. We work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology. To brief you a little bit about the webinar and the need for this webinar, in India, the incidence of epithelial ovarian cancer is estimated to be around 5.2 per 1 lakh women. It is the seventh leading cause of cancer-related deaths among women. Worldwide, epithelial ovarian cancer is the fifth most common cancer among women, with an estimated 296,000 new cases and 186,000 deaths in 2018. It is the leading cause of death from gynecological cancers. In this webinar, we will discuss the genetics in epithelial ovarian cancer, current landscapes of PARP inhibitors in the treatment of ovarian cancer, and explore the potential future directions for this therapeutic approach. We hope that this webinar will provide you with a better understanding of PARP inhibitors and their potential role in the effective treatment of ovarian cancer. On that note, we can move on to the lectures. We have with us two eminent professionals from the field of oncology, and it gives me immense pleasure to introduce the speakers for today. The first speaker is Dr. Sambit K Mohanty, Senior Oncologic, Surgical and Molecular Pathologist, Head of Clinical Research for Diagnostics, New Delhi, India. Dr. Sambit Mohanty is a nationally and internationally acclaimed American board certified pathologist. He completed his MBBS in SCB Medical College with 12 university gold medals and record of honors with Best Graduate Award. His MD degree was done in PGI, Chandigarh, and Beth Israel Deaconess Medical Center at Harvard and New York University, with the US Board and recipient American Molecular Pathology and CAP Travel Awards. He received the Best Postgraduate Gold Medal during his residency at NYU. He is also the recipient of Staubel Orbison Award thrice during his residency in the US for the best poster presentation and had multiple presentations to his credit. His clinical fellowships are Oncologic, Surgical, Women's Health, Urologic, Digital and Molecular Pathology from centers like Memorial Sloan Kettering Cancer Center, University of Pittsburgh, and Cedar Sinai Medical Center. His affiliations are Associate Professor of Pathology at the Cedars-Sinai Medical Center, Los Angeles, USA. He has been actively involved in clinical diagnostics, teaching, and translational research for the last 22 years, with over 200 publications in reputed peer-reviewed journals and 307 presentations in various national and international conferences. He has an international collaboration on cancer reporting for kidney tumors and National Comprehensive Cancer Network for the same. He is the editorial and review board of International Journal of Surgical Pathology, Indian Journal of Pathology and Microbiology, Human Pathology, Cancer Research, Endocrine Pathology, and American Journal of Clinical Pathology. So welcome, sir. The next speaker is Dr. Sourav Mishra. He's an associate professor, Department of Molecular Oncology, Haematology, AIIMS, Bhubaneshwar, India. As the first medical oncologist in AIIMS, Bhubaneshwar, Dr. Sourav Mishra had the opportunity to start and develop the department brick by brick. As the functional head of the division of medical oncology, he has the overall in charge of all activities in the department. It is first dedicated department of medical oncology in the government sector of Odisha. He completed his DM degree at the Cancer Institute, WIA, the Dr. MGR Medical University, Chennai, India. He completed his MD in Institute of Medical Sciences, Banaras Hindu University, UP, India. Dr. Sourav Mishra has received Times Health Icon Excellence Award for the best medical oncologist in the state of Odisha, India, in April 2021. He was one of the 5 founder directors of the Utkal Cancer Care, which is a dedicated first in the state of Odisha individual oncology daycare, which was established in July 2020. Despite the pandemic caused by COVID-19, the daycare successfully went on to complete 2 years providing dedicated patient care. Along with his team, he strives toward providing the best comprehensive care to cancer patients. On behalf of the International Association of Oncology, I would like to take this moment to express a heartfelt gratitude to our expert speakers, Dr. Sambit K Mohanty and Dr. Sourav Mishra, for taking your time to share your vast knowledge in this topic, despite your busy schedule.
Thank you. Thank you.
Thank you.
Now, I would like to invite Dr. Sambit K Mohanty to take over the session. Meanwhile, participants, if at any point you have any questions or doubts, you can leave those questions in the chat box. And we have a question and answer session where the speakers would address your questions. Please take over, sir.
Yeah, thank you, Pauline. Thanks for the kind words and good evening, everyone. So let me share my screen. Am I audible to all of you?
Yes, sir.
Okay. Is it full screen now?
Not yet, sir.
Okay, I mean, let me just close it and open it again. 1 second. How about now?
Yes, sir, it's full screen now.
Okay, cool. So thank you, everyone. Thank you, International Academy Association of Oncology and the Biologics. I have been associated with them twice before with Dr. Biswas and Dr. Mishra in the conferences. They've been doing really nice and great work across the country. And Sourav and I have been collaborating in research for the last 5 years almost, Sourav, right? And published a lot while I was in Odisha even now.
Yeah.
So this is something which is very close to my heart. I will start the gynecologic and urologic pathology. So what I thought I will just for the next 30 minutes, we'd play around with various morphologic parameters and what we do in the molecular lab. So I put it as molecular microscope. So as this is like something everybody knows, like there is about a total of 313,959 estimated ovarian cancer in females of all ages. And this is by the Globocon 2020, where Asia is on the top. So the incidence, if you see for the ovarian cancer is 3.4%. I'll come to the Indian data in a while. And the mortality is 4.7%, and it is not like one of the top cancers, but it is kind of going up. And in 2018, ovarian cancer ranked as the 8th most common cancer diagnosis and the cause of cancer death in women, with an estimated of 295,000 cases and 184,000 deaths worldwide. So if you come to cancer, ovarian cancer in India, it is the 3rd most common cancer in the women in Indian population. And about half of the diagnosis of ovarian cancer are made only in the later stage, that is in the stage 3 or the stage 4 of the cancer. And in our country, about 60,000 cases have been estimated as a new ovarian cancer by the end of 2020. And the incidence of these tumors or these malignancies is estimated to increase to 371,000 a year by 2035, which is about a 55% increment, while the death rate increases even more, is about 70% to 254,000. So, and it is the 8th leading cause of cancer-related mortality and the most lethal gynecologic malignancy. And if you go by the United States data with the CS statistics, is 11.6 cases per 100,000 women per year, and the 5-year survival is 47.4%. Average lifetime risk is again 1.3, risk of mortality is 1%, and at the time of diagnosis, it's about 80% are advanced and only 20% are 5th are in the early stage. So this, if you see, the new cases are mostly diagnosed between 50 to 64, or if I combine these two, between 45 to 74, and the death is maximum as you go older from 55 to 85 years. And there is a decline after 85. So the current WHO, I'll go by the current WHO because I was involved in the WHO for the GU system, not for the gynecologic tract tumors. But the current WHO has made a few changes to the classification of surface epithelial tumors. I'm not going to touch upon the germ cell or the tumors from the sex cord or the stroma or the metastatic and the other tumors. So I'll just focus on the surface epithelial malignancies because we have the PARP thing going on. So we have the classic subtypes are still there, the serous, mucinous, endometrioid, clear cell, seromucinous, Brenner, and the other carcinomas. So with a few changes. So what we are going to talk for the next 20 minutes, the key concepts in the pathogenesis or the genomics of ovarian surface epithelial tumor. Fallopian tube is the primary origin of certain ovarian cancers. And we need to subtype it while looking at a slide, either the resection specimen or by doing immunohistochemistry, because the treatments are different and molecular underpinning is very, very crucial. So the pathologist, they play an important role in typing, staging, and if possible, molecular characterization of the ovarian surface epithelial tumors that influences treatment and prognosis. And we need to understand the changes in the current WHO 2020 5th edition and the role of HRD and HRR, homologous recombination repair and the defect, and the role of PARP in high-grade ovarian cancer. So the major changes in the WHO are, it is largely unchanged, I would say. Endometrioid carcinoma of the ovaries needs further subtyping. Is the pole mutated or not? And further, we can divide them into a MSI high or a labile, or it is a tumor without any known or no specific molecular alterations. And this seromucinous carcinoma was dropped as a distinct category, which is still present within the major category of tumors. So if I go by this, I think there is a question. We can always take the question towards the later on, and I can always take the question.
So, sir, can we take the questions right now? It would be, or should we?
I think we can do it at the end, and that way it would be easier.
Fine.
Yeah.
Fine.
Yeah. So if we go by the origin of tumors of the ovary, as you know, we have the fimbria constantly beating on the ovarian surface to get the egg out of it so that the sperm can meet and there will be a zygote or there'll be fertilization. But what happens? So in the fallopian tube, if you start with a high-grade serous carcinomas, I do see reports when I was new in the country, I do see reports, people writing um, papillary serous carcinoma of the ovary. I mean, what is it? Is a low grade or a high grade? So this is very, very important to know. Serous carcinomas, clear cell carcinomas, undifferentiated, and carcinosarcomas are bona fide grade 3 tumors. There is, if that, there is a small percentage of serous, which about less than a 5% are low grade serous. They have a distinct histology and they arise from the serous borderline tumors. But high grade serous is a major chunk, about 70%. And they arise from the dysplastic epithelium or the transformed epithelium of the fallopian tube, particularly the tube, the cells of the fimbria. And the inherited syndromes which are associated with that are the BRCA1, 2 deficiencies, a hereditary breast and ovarian cancer syndrome. Common mutation is the mutation in the TP53. Either you see TP53 staining as a Christmas tree, or there is complete loss of staining, or there is cytoplasmic positivity, to call it as a IHC surrogate for the mutation. And PARP is the answer for those tumors. Clear cell and mucinous. So think, and mostly the clear cells probably arise from the endometriotic foci. They have a different, I mean, they show a little different pathway. They are not TP53 mutated tumor. Classically, clear cell carcinomas do not have P53, though we had a few cases of TP53 mutated clear cell cancers. And the other players in the clear cell are the PIK3CA and MSI microsatellite defects, and the drugs for them are tyrosine kinase inhibitor. Endometrioid, they arise from the endometrioid borderlines, and they have loss in the mTOR, TSC1, TSC2, PTEN pathway. So that is the tumor there. So we need to look after mTOR pathway to defect. I mean, either there is a TSC1, TSC2 loss, the tumor suppressor gene, there's a PTEN loss, or activation of the mTOR or PI3 kinase. Low-grade serous carcinomas, they arise from serous borderline tumor. They show BRAF and RAS mutation, and they can be tackled by MEK1 or 2 inhibitors. Mucinous are again, either they are RAS mutated or they have an amplification of HER2. So if I compare these two pictures, one on the left is extremely ugly. The cells are humongous with a lot of defect in the chromatin, which I can see from here with the increased DNA content of the cell with a mitosis. And so this is an aggressive high-grade serous carcinoma, and they are more chemoresponsive and they may be candidates for PARP inhibitors, whereas low grades are indolent disease, but they are less chemoresponsive. They look very, very well organized, low cytologic atypia. They may have benefit with MAP kinase inhibitors. Then what is this origin of high-grade serous carcinoma? This is my normal fallopian tube. If you see, this is the normal fallopian tube with the ciliated cell and the secretory cells and the intercalated cell. But what you see suddenly, there is multi-layering. There's a lot of layers, and what you see is a lot of nuclei, though no cytoplasm. I mean, it's not visible. So that means there is an increase in the nuclear to cytoplasmic ratio, and the cells are on the top, and they're losing out the cilia. And if you do a Ki67 or a MIB in staining, it is going to be very high. Ki69 would be like Christmas tree, and P53 would have a diffuse nuclear staining, or there is a diffuse cytoplasmic staining, or there is complete loss of P53 staining. And why? That is because of a missense or a nonsense mutation of the TP53 gene, and this is nothing but serous intraepithelial tubal carcinoma or stick lesion. So high-grade serous carcinoma arises from this stick lesion, and this is a classic example from our medical school days, what we say some of our bodies and high nuclear grade, lot of mitosis. So this is what we are going to talk for the next 10 minutes probably, or I'll be a little more like 20 minutes. So what are the genetics in ovarian cancer like any other cancer? So high-grade serous carcinoma, 95% or more than 95% have TP53 mutation, which is either missense or nonsense. About 20% have a BRCA1 or 2 mutations. These are tumor suppressor genes. So there is either loss of heterozygosity, or there is biallelic inactivation, or point mutation, deletion, or duplications, and multiple things which can happen in this. Roughly 50% are germline and 50% are somatic. Germline mean it's present in every cell of the body and is picked up by the peripheral blood testing and associated with a familial cancer syndrome. Whereas somatic is limited to the tumor cell and is not present elsewhere in the body, therefore is only picked up if you test the tumor cell. And about half of these tumors have homologous recombination defect. I'll come to that. What is it? While BRCA mutations are the most common cause, BRCA is one of the gene which is responsible for homologous recombination DNA repair. There is another gamete of gene which are responsible for that. And so BRCA is not the only cause. Therefore, the presence of a BRCA mutation implies HRD, but the presence of HRD doesn't always mean that there is a BRCA mutations. So I would request everyone not to raise your hands now. You can always ask the question after both of us finish the talk or after my talk, or you can put it in the chat box. So what is homologous recombination and where it is associated with, and the genes associated with HRR and all these things. So there's a paper, there's an old paper about like 8 years ago on germline and somatic mutations in homologous recombination genes, and that can predict platinum response and survival in ovarian, fallopian tube, and peritoneal carcinomas. If you see this diagram, about majority of BRCA1, about 54%, and 21% is BRCA2, but there is a major chunk where BRCA is not associated. So they are predominant, but not the only players for homologous recombination defect. So what is PARP? So let's talk about PARP first, then we'll go into HRR. So PARP is a poly-ADP ribose polymerase. So this is a DNA polymerase. And you know DNA polymerase is responsible for DNA replication or DNA repair. So we basically, when there is a defect, we need to take that portion out and synthesize and fill up the gap. And it catalyzes the transfer of ADP ribose to the target protein. It helps in chromatin remodeling, transcription, replication, recombination, and DNA repair. So PARP proteins and the DNA repair, they are like sisters. They are very closely related to each other. And tumors with a defective homologous recombination repair mechanism, because that rely on PARP, are sensitive to the inhibition. So if a tumor which has a defective homologous repair mechanism, that means the tumor is highly dependent on PARP for the DNA repair. Unless the DNA, because the tumor cell DNA is also under the stress of normal stuff as well as chemo radiation. So if the HRR genes are defective, so tumor cells are completely depending on PARP to at least in a major way, they're depending on PARP for their survival through DNA repair mechanism. So if we can do something on some mechanism to inhibit that mechanism, we can achieve. We can get rid of the tumor. So PARP inhibition results in genomic instability and accumulation of damaged cell in the cell cycle. So if you inhibit the PARP, what happens? The cell would not go from G2 to M stage, M phase of mitosis. And it has a dominant negative effect. It inhibits mitosis, and the cell will undergo apoptosis because it cannot enter mitosis. And it is an attractive candidate for therapeutic inhibition in combination with chemo and radiation. So if you see this one, if there is in a normal cell, this is the DNA, the double helix structure, there is a defect. So it's a single-stranded break, and it is repaired by PARP, and so the single-stranded break is repaired, and the cell is going to survive. And if you're giving a PARP inhibitor, the single-stranded break cannot be repaired. So it is converted to a double-stranded break. There is another break here. And if the cell has homologous recombination genes like BRCA1, BRCA2, ATM, CHEK1, CHEK2, PALB2, there's a big list. So the double-stranded repair would be proficient, or there is this is the HR proficient cell or HR proficient tumor where the cell is going to survive in a normal cell. So take an example of a normal cell. If in a normal cell you're giving PARP, the cell is still going to survive because the normal cell has normal HR pathway genes and the proteins. But if there is HR deficiency, like in tumor cell, the tumor cell is going to undergo apoptosis. So what is the difference between HRR and HRD? There are important features in DNA damage response. This is not my slide. I copied it from the internet. I didn't have the space there to acknowledge. So I'm sorry for that. And it looks a little fuzzy. So homologous recombination repair is a word, and there is another word is called homologous recombination deficiency. These are important features in DNA damage response that relate to prognostic and treatment outcome for patients. Excuse me. So HRI is the process, that is homologous recombination repair, which just discussed. It is essential for error-free DNA damage repair and maintenance of genomic integrity or DNA integrity. What it does is fixes the double-stranded breaks, which are the most genotoxic form of DNA damage. So if there is a single-stranded break and there is PARP, then it repairs. If the PARP is not functional, then HRR fixes the double-stranded break, or if there is a double-stranded break to begin with, it is taken care of by the HRR gene. And HRR, when it is compromised, leads to genomic aberrations and genomic instability. The BRCA genes are considered at the prototype and the most understood component of HRR pathway. And what is HRD, or homologous recombination deficiency? It is the consequence of losing HRR capability. So one is a process and one is a deficiency. So if you lose it out, what is going to happen? And it is characterized by genomic instability. That means there is mutation or epigenetic changes in the promoter region of the gene, which is methylated, so the gene is not functional in one or more of the HRR genes. So either there is a mutation in the HRR gene or there is some epigenetic change. Therefore, the tumor cell, they compromise these genes to perform homologous recombination repair. Cells with malfunctioning HRR rely on error-prone pathways such as non-homologous end-joining repair. So if a tumor cell has HRR defect, that means the tumor cell has to survive. So it takes the help of error-prone pathway, and which is otherwise called non-homologous end-joining repair of the double-stranded breaks, leading to accumulation of genetic aberration, genomic instability, and more tumor. Such aberrations can be loss or rearrangement of the sections of DNA, including the entire gene. This phenotype of loss of HRR capability and associated genomic instability is called. So either you are getting a rearranged or a duplicated portion of DNA, or you are getting other double-stranded repairs. So that leads to homologous recombination deficiency, or HRD, and that is what we see in ovarian serous cancer, the HRD score. In prostate cancer, we do not have HRD. We say it is HRR, homologous recombination repair deficiency, but we do not have an HRD score. HRD score we get in high-grade ovarian cancer, serous cancer. So this is what I already discussed. So this is if there is a single-stranded break, it gets repaired normally by the PARP, and if you give PARP inhibitor, then single-stranded become a double-stranded normal cell repaired by homologous recombination genes. And if it is mutated, there is no homologous recombination repair, leads to cell death. I think Dr. Sourav is going to talk about synthetic lethality. I'll just touch upon 2 points. Inhibition of PARP in cancer treatment, it increases the tumor sensitivity to chemotherapeutic agents that damage the DNA. And there, how it does, it induces synthetic lethality, which is the process in which the tumor cells are highly dependent on PARP due to deficiency of homologous recombination mechanism. So they have only one way out. If you knock off that, then there is no way for them to survive. And that is nothing but synthetic lethality. So Again, this is for the medical oncologist to discuss, but I'll just touch upon a few points. In addition to the gross and microscopy staging and grading information, as pathologists, we are obligated, if the facility is there with us, if not, at least to send it to another higher center. In the upfront test, in upfront setting, when you have the tumor with you, for a somatic testing at a minimum to optimize identification of various alterations, including the homologous recombination repair pathway and the deficiency score. So genetic testing, like in other tumors, is increasingly important in the complex care of patients with ovarian cancer and their at-risk family member. So identification of the individual with pathogenic variant has implication for targeted therapy, various recommendation, risk reduction therapies, increased surveillance, and genetic testing for the family member. And so therefore, pathology and radiology are crucial. So if you say any tumor, we have like 70 to 80% are sporadic. The cancer occurs due to chance or due to other factors. Hereditary cancers are 5 to 10% of all cancer, which are inherited from in the family and have significantly increased cancer risk. And about 20% are due to multiple genes and environmental factor. So they have some increased risk. So if I get into not the breast, I'll get into the ovarian. So BRCA doesn't, as I said, approximately capture 1/4 of the ovarian cancer, and these are the various players. So for the hereditary ovarian cancer syndrome, BRCA1 and BRCA2 genes are the tumor suppressor gene present in the chromosome 17 and 13 respectively. They are not gender specific, and variation in these two genes account for 25% of breast cancer, but is more for ovarian cancer, about 75% of the hereditary ovarian cancer. Triple negative breast cancer and ER positive breast cancer, you know, I'm not going to talk about that. And although it is highly penetrant, 20 to 30% carriers do not get cancer. And de novo mutation can occur in the sporadic setting in the tumor without having a germline basis. So if I get into this, I'm not going to discuss. This is for the breast. I'll go to the genetic testing beyond BRCA. So it can have syndromic thing, like you can have a Lynch patient with an ovarian cancer and endometrial cancer risk of 4 to 12%, which involves the dimers like MLH1 and PMS2 or MSS6 and MSS2. It can be with Peutz syndrome, Lee-Fraumeni, which is a typical TP53 disease, and Cordon syndrome, which is a loss of PTEN. So if I get into the PALB2, which is another HRR pathway gene, it increases lifetime risk of 33 to 58% for breast and increased ovarian cancer risk throughout the lifetime. So if I get into the various clinical syndrome for breast and ovarian cancer, starting with the BRCA1, the lifetime ovarian cancer risk is 40%. For BRCA2, it is 18%. And if I go for STK11, which is again for ovarian is 55, for MMR deficiency, it is 4 to 12%. For CHEK2, it is again high. And for PALB2, there is PALB2 and CHEK2 and CHEK1, there is an increased risk. The exact number is not there. And for ATM, again, for breast and ovarian, it's higher than the general population. So what is the purpose of a genetic test? If a mutation is found, then testing the family member. Then are we going to provide appropriate medication related to the variant? They need to inform about the potential risk of different cancer and preventive measures for the patient and also for the family, that is a lifetime risk assessment, or deciding prophylactic surgeries for the patient or the family. So what test is correct? That is also important. So consideration of the most appropriate test to order. So there are a lot of questions. The patients are very well educated. They read a lot of things before they come to you. Somatic testing, germline, one gene, multi-gene, hotspots, VUS, so those kind of things. So somatic testing when they are concerned about chemosensitivity or targeted therapy, germline to assess the risk versus diagnosis, liquid biopsy to look for minimal residual disease, an unresectable tumor. Single gene, we're checking for a single gene involved in the cancer, confirmation of a genetic variant in the gene of interest. Multigene, when specific to various cancer types and recommended by the guidelines, or checking for the common mutations in that tumor, which are the drivers. So choosing the correct genetic test, single versus multigene. Single gene, when the pedigree is suggestive of a known genetic predisposition, considered pathogenic or a likely pathogenic variant detected in unaffected family member. So you consider this when you have a pathogenic or a likely pathogenic variant in an unaffected family member, that means non-affected in the by the tumor. If more than one family member is affected with different cancer associated with particular inherited cancer variant, consider testing of the member with the youngest age of diagnosis, like for BRCA 1 and 2 in ovarian and breast cancer, prostatic and pancreatic cancer. In children less than 18 years, this is an important point which I put in yellow. Genetic testing is generally not recommended when results would not impact medical management. It is from the NCCN. Multigene, when to go for multigene testing? When the individual is negative for single syndrome, but a family history remains suggestive of inherited susceptibility, more than one family member indicated of inherited cancer syndrome, phenotype-based tailored multigene panel should be considered. Testing of unaffected family member should be considered when affected member is deceased. So these are the few things you need to remember for single gene and multigene, and these are basically the job of the genetic counselor who helps us a lot in deciding what test and when to do. Then for BRCA, you know, we have a big gene, 84% of the gene can be tackled by NGS, but the rest 16% we need an MLPA assay, because MLPA can take care of the large duplications and deletions, which is not taken care by the NGS assay. And if it is negative by the NGS, you go for an MLPA. We offer both together, then you can cover, you are basically covering the comprehensive, the entire gene. So this, I think, Sourav is going to discuss. So the next one is BRCA somatic. If the somatic BRCA is negative by both the test, you go for an HRR somatic. If it is HRR somatic inconclusive, you go for a HRR germline. And why it is important, why you're basically chasing after these genes, because we want to decide what therapy to be given. And if the variant allelic frequency, which is very, very important, in case we have a somatic testing for BRCA or for HRR, where the variant allelic frequency is more than 50%, that means there is something which has a genomic germline basis, so consider a germline testing. So if you have a 15%, 18%, 23% variant allelic frequency, when you look at the coverage and the VAP, in the NGS reporting, if it is more than 50%, that means chances of a germline positivity is very high. So you go for a germline testing. For HRR germline, gene-based recommendations and risk analysis in family positive, and personalized recommendation is based on the clinical history and clinicians' discretion. So homologous recombination repair. HRR genes are involved in the repair of damaged DNA. Mutations in genes can lead to deficiency in the repair of damaged DNA. Sensitivity to PARP inhibitor therapy in certain cancer types like ovarian and breast cancer, and the clinical application is prognostic and predictive biomarker for platinum-based therapy and PARP inhibitor therapy. Platinum-based chemotherapy has been shown to be more effective in ovarian cancer with HRR mutations, either germline or somatic, and mutation the HRR gene, which are the HRR defective tumors. Just a word about triple negative breast cancer in predictive of complete pathologic response in these tumors. So HRD for ovarian cancer, both somatic and germline, positive, you decide what to do. And these are the various drugs. I am not a treating physician, so better should not talk about it, but the test would be for ovarian cancer, germline and somatic. And for HER2 negative breast cancer, germline BRCA and BRCA2, for pancreatic germline, and for CRPCs, metastatic CRPCs, we have germline and somatic for the HRR gene, and just about a ward for prostate cancer, any tumor with a higher cribriform pattern or radioresistance, they harbor more HRR mutations. Then for clinical and therapeutic significance of HRD, advanced ovarian and fallopian tube and peritoneal cancer, for HRD positive, they're the drugs, and then genetic counseling and how it helps. So it comprehends the medical facts, including diagnosis, probable cause of disease management, inform about the age of onset, mode of inheritance, penetrance, and expressivity of the defect, recognize the way hereditary factors contribute to disease and disease recurrence. Communication with the family through education, psychological support, which we should not do. Choose the exact course of action in the view of risk, economic status of the family, ethical and religious values. And so this is the way it works. We start from here, then we go this way. But the final result is a good communication, psychological support, empathy, and education, which a physician should not be doing. For that, we have oncopsychologist and genetic counselor. So pre-test counseling done prior to the ordering the test. You should discuss about outcomes, including variants of unknown and undetermined significance, then consideration of the most appropriate test to order, and post-test counseling results were disclosed. You discuss the result, screening recommendations with the patient before you send the patient again back to the oncologist. What is VUS in this setting? A genetic alteration that may actually represent a benign polymorphism unrelated to an increased cancer risk or may indicate an increased cancer risk. More than 90% of the time, if VUS is reclassified, it is downgraded to a benign category or a likely benign category. VUS may lead to confusion regarding medical management, can be part of familial variant. Family members should not be tested for a VUS for the purposes of clinical management unless there are conflicting data between laboratories regarding the classification of a variant. And VUS and likely benign variants should be managed based on cancers present in the family. Screening and prevention strategies. So like for ovarian, you have risk reduction surgeries, typically between 35 to 40 years and upon completion of childbearing, counseling and addressing benefits and limitations of hysterectomy. Then BRCA screening, and this is for the breast. So this is what NCCN and other guidelines they recommend. So with this, in a short, I basically discussed about the various genetic player, what is HRR, and so what I will go to the, can I just close this and go to another PowerPoint, and shortly I'll discuss about what we accomplish so far at CORE with our partners.
Please go ahead.
Sure, thank you.
Sambit sir, I think you can take the questions and before you play the next slide deck.
We can have it together actually, not a problem. Okay. We can have it together, yeah.
Okay, at the end. Fine.
Yeah. Is it visible?
Yes.
Yes, sir.
Okay. So what we did, it's basically Dr. Shivani, who is not there in the group right now, and the entire molecular team, along with me, I was mentoring the project. So we did a genetic analysis with our partners, and hopefully our oncologists have helped us a lot, including Dr. Mishra, in providing the cases. So we looked into the data of 1,282 patients of BRCA1 and BRCA2 and other HRR gene defect, both by germline testing and by somatic testing. And I'll go by, this is the overall data. TNPs, but the test is not performed because the sample was inadequate. The specimen volume, there's a lot of necrosis and fibrosis. So these are the complete code. So we looked into the complete coding region and the splice junction of HRR pathway genes. And these are the various genes. And it's sequenced by Illumina sequencing platform as a 1000x mean depth. So these are the various genes like BARD1, BRCA1, BRCA2, CDK12, CHEK2, CHEK1, PALB2. And this is the list of gene. TP53 is also included. And then the right is the coverage. So I'll get into the number for BRCA. For if you see ovarian germline BRCA is 23% and ovarian somatic BRCA is 16.7%. And if you go for BRCA2 in ovarian, it is 13.3%. And for somatic, it is 20%. And then similarly for somatic BRCA is 13.8 and BRCA2 is 10.8 in the HRR panel. Other HRR gene would be like positive cases is 52.3% for ovarian tumor. And for germline, it is other HRR gene is 10.9 and BRCA is 14.5 for 1 and 2 is 10.9%. So this is what we just gathered in a study. So thank you very much again, and I can take the questions right now.
Thank you, sir.
Okay.
First of all, thank you, sir, for such a detailed, interesting presentation.
Yeah.
Moving on to the questions. The first question is from an anonymous attendee. The question is, does the subtyping allow for better understanding of tumor heterogeneity?
Can we unmute and I can understand the question better?
Yes, sir. Just give me 1 second. Just having trouble finding out.
I mean, exactly, it is not the answer. It's not the subtyping we do because the genetic players are different in the different tumors. It is not with tumor heterogeneity, the terminology is used within one tumor. There is one tumor, like for breast cancer or for like an any tumor. So if we have a mixed, these are basically two things. One is a pure morphology versus a mixed morphology. So as morphologist, when you look at the case in pathology, we'll try to give it a name. And if we cannot, we say it's a mixed tumor with this and this histology. I'm talking about a surface epithelial ovarian tumor. Heterogeneity is what? Suppose a tumor is HER2 amplification in one portion and HER2 amplification is not there in the other portion. So these are various subclones within the same tumor, some with a defect and some would not have a defect. So subtyping is very different. Subtyping is something we do by morphologic assessment or by IHC. And we go for variants, that means we have a tumor which is has a defect versus a tumor which doesn't have a defect. And heterogeneity is within the same tumor, a portion has a defect, a portion doesn't have a defect. So there are three different terminologies. We should not kind of mingle those together. One is subtyping, one is variant, and one is heterogeneity. So among various tumors, there are different subtypes. Subtypes can be further classified in a better way by doing genetic testing as variants. And within the same variant, we can have intratumoral. It is intratumoral heterogeneity, whereas subtyping and variants are intertumoral. Heterogeneity is an intratumoral process. What is the region for the most cancer? Is it clear to whoever asked that question? Okay. So the next one is, what is the region of most of the cancer origin being fallopian tube? I do not know. And then the question from Professor Kamal Krishna Banik, can you unmute Dr. Banik?
Yes, yes, all right. Yes, sir, he's here. Professor Dr. Kamal, you could probably elaborate on the question, sir.
Because yeah, dysgerminoma we should discuss in some other lecture. The focus of this lecture over surface epithelial malignancies because and know about the genetics and how the PARP works and the PARP inhibitors work. So probably because of that, I did not discuss about the sex-caused stromal tumor and the germ cell tumors. Any more question? Because a lot of people, they raise their hand. 3
If you have any
participants.
questions that you would like to ask Dr. Sambit, you can just put in the chat. I would give you access to talk.
Or they can ask also. They can.
Yeah, we have
You can
Dr. S. Praveen and Dr. Benavli. So Dr. Praveen and Dr. Benavli, they have raised their hands, but we are not getting questions from them. Are they there? Dr. S. Praveen.
They can unmute and ask.
Yeah.
Yeah, I've given them access to speak.
Yeah.
Sir?
Yeah.
Yeah.
So NGS at different centers is known by the number of genes included in their panel, like 50 gene, 30 gene panel.
The broader gene is like for the human cancers, we have about 500 to 600 gene that cover the entire the cancer causing genes in the human cancer.
Okay.
So the more yeah, please go ahead.
So for HRD, how many genes should be
we have the panel
including?
We have the 11 genes which are included. I showed you in the picture in one of the slides.
Okay, sir. And one more thing, not related to serous carcinoma, but what is the role of PTEN IHC in endometrioid carcinoma, sir?
PTEN IHC has a lot of value. I mean, see, for endometrial cancer, if you have an your question is between endometrioid versus serous. If there is loss of PTEN IHC and you have see, the scenarios are very different. If you have a high-grade tumor,
yes,
high-grade tumor can be high-grade serous or a high-grade FIGO3 endometrioid.
yes,
so in that case, if your P53 mutation is negative and P53 is negative or a wild type abstaining and P10 is lost, and the cells do not have P16, then you can comfortably say it is high-grade endometrioid. But about 1/4 of high-grade endometrioids, they do have P53 mutations. So if there is P53 mutation along with P10 loss, it is kind of difficult. Then you give an opportunity for the P16 IHC. If P16 is positive, you tend more towards a serous carcinoma. If P16 is negative, you go towards endometrioid. We do use P10 regularly here. It is good. P10 has a lot of value when you questions. If the questions are between a high-grade serous versus high-grade endometrioid, or endometrioid versus serous, or endocervical versus endometrial, within the uterus, it has no value in the ovary.
Okay, sir. Is it very commonly used, sir, PTEN IHC?
We have been using it for like, I think this is our 4th year. We are using 4th or 5th year. For the last 5 years, we're using PTEN IHC.
Does it have any predictive value, like in hyperplasias? If we do P10, can we predict the risk?
Do not do P10 if you have a question between disordered proliferative and hyperplasia. I mean, if you do hyperplasia, I have seen P10 loss in non-atypical hyperplasias. Even in non-atypical hyperplasia, I have seen P10 loss.
Okay, so it doesn't have much value.
In those settings, I would not recommend P10. If you're doing a combination of Ki67, P10, and PAX2, that helps. I'll share that picture, that article probably with Pauline, and she can send it to everyone. There's an article one of my friends just published with using a triple cocktail for differentiating. Again, it's P10 is a difficult strain when you have a question between atypical versus non-atypical hyperplasia or atypical hyperplasia versus cancer.
Okay. But if we do it as a panel like this, then probably it can have...
it helps me, my experience, because I do it regularly. It helps me if I have a question between endometrial versus endocervical or high-grade serous versus high-grade endometrial. These are the two scenarios where P10 helps me.
Okay, sir. Thank you, sir.
You're welcome. and by Dr. Parveen.
Dr. S. Parveen? In the meantime, so we have another question from Isha. The question is, how can reduce the incidence of ovarian cancer? Is there any chance to reduce?
That is a question for Dr. Sourav. I'm not a clinician.
Okay.
So basically, the risk ovarian cancer, the risk factors, if you see, mostly some of them are genetics, that is cannot be modified, so non-modifiable risk factors. And suppose someone has inherited, you cannot do anything about that. Other ways, if someone has got a deleterious mutation which can predispose to ovarian cancer, there are risk reduction surgeries, as was shown by Dr. Sambit, that if you go for such risk reduction surgeries, there is almost a 90% chance that you won't be having these sort of cancers, both for ovarian cancers as well as for the peritoneal carcinomas, primary peritoneal carcinomas. So otherwise, nothing much to say. There is not a very great role of screening to diagnose any ovarian cancer. So screening is not a routine stuff in ovarian cancers. So basically risk reduction surgeries could be one of the ways of reducing the incidence of ovarian cancers in those who have these mutations. Is it okay?
I hope, yeah, it was clarified.
So do you have any more questions?
We don't have any as of now, sir. I think that would be all for now.
Okay.
And again, I want to thank Dr. Sambit and now Dr. Sourav Mishra. Please take over the session.
Yeah. So I'll share my slide deck, right?
Yes, sir. Please.
So thank you, Dr. Sambit, for making my work easier. Actually, basically, you have taken the sessions, and in that session, you have actually covered some of the very important concepts. I'll also be going through those concepts still because they are relevant in my clinical context. So if at all I'm going to present data about the targeted therapies, that is the PARP inhibitors, in ovarian cancer, I have to also go through and touch over these concepts also. So this is the place where I work. So as was said, when there is a damage in the DNA, there can be variety of damages. There can be single-stranded breaks, there can be double-stranded breaks, and there could be other types of like mismatch repair. These are variety of DNA damages. Now, when there is a variety of DNA damage, so the repair mechanism has also to be variety. So we have here for single-stranded DNA breaks, we are having the PARP enzymes, which was discussed. And for the double-stranded DNA breaks, we have either the homologous recombination genes, as was alluded before, there are a lot of genes in that group, or the non-homologous enzyme. So these would behoove us to take subsequently the role of both the PARP as well as the BRCA, and what happens if we inhibit the PARP. So if any of these enzymes which are responsible for the DNA repair, if they are defective, then what will happen? So something known as genomic instability will happen. Why? Because the genetic aberrations, the genomic instability means if there is a deleterious mutation in the BRCA, what will happen is that there will be genetic aberrations that increase the mutation rate and expedite the accusation of driver mutation. So when such a BRCA mutation happens in a cell, that cell is prone to have a genomic instability, and by virtue of this genomic instability, it is liable to acquire more driver mutations, ultimately transforming into a cancer. And where do these driver mutations are acquired? They are acquired in the oncogenes and the tumor suppressor genes. So that is why the risk increases over the baseline in those patients who are having any of the mutations in the BRCA genes. That is what predisposes them to variety of cancers. So double-stranded breaks was discussed. It is important. These are one of the very, very important DNA damages, and repair is essential for cell survival. So among the variety of types of DNA damage, the most deleterious ones are the DNA double-stranded breaks, and what repairs the DNA double-stranded breaks? BRCA is the gene responsible for repair of this. So what happens when the double-stranded breaks are formed in a large number? So double-stranded breaks can be generated. How come they are formed? Either by the reactive oxygen species, which can cause cellular damages, or replication associated errors. During the time of replication, there may be double-stranded breaks, as well as by some exogenous sources like the ionizing radiations and chemotherapeutic agents. So this is how the double-stranded breaks are generated. And what happens if they are repaired? Then the cell survives. What happens if they are unrepaired? If suppose there is something and some pathway is defective and these double-stranded breaks are not repaired, so if they are not repaired, that will lead to cell death. And if that is accurately repaired, then the cells go on for normal survival. And if there is insufficient or inaccurately repairing of the double-stranded breaks, can result in survival of cells showing genomic alteration that may contribute to the tumor development. So there are three scenarios: either complete activity of the BRCA gene, so any defect is there in double-stranded DNA repair. So if there are any double-stranded breaks, and if the BRCA is normal, absolutely that is repaired, and there is no deleterious effect to the cell. If there is complete deficiency of the BRCA, then what will happen? So then what happens is that if unrepaired, these double-stranded breaks, they can lead to cell death. If they are insufficiently repaired, then these double-stranded cell breaks, although the cell will survive, but it will acquire more genomic alterations and contribute to the tumor development. So what is the pathway which is responsible for repairing of this DNA double-stranded? This was already discussed. These are the homologous recombination repair. So there are a lot of mediators in this pathway, and all of these in one way or the other, they come together and they lead to homologous recombination repair of the DNA double-stranded breaks. We won't go to the details of it. Now, with that background, that there are homologous recombination repair genes or HRR pathway, and that the BRCA1 and BRCA2, they are also an important component of this homologous recombination repair pathway. And these two genes, they are as was discussed, they are inherited in an autosomal dominant manner. But these are tumor suppressor genes. They are functionally recessive. That means both the copies of the genes have to be. If there is only one copy which is abnormal, the person doesn't develop cancer. So both the copies have to be mutated in order to exert its effect. So functionally, it is a recessive gene, autosomal dominant mode of inheritance of this tumor suppressor gene. And you can see here the responsibility of BRCA is to go for double-stranded DNA break repair. So if there are mutations in these genes, then we can have a lot of cancers, most common of which are breast and ovarian cancer. Subsequently, we'll also see that those patients who have a BRCA mutation, let us say a patient has ovarian cancer and has a BRCA mutation, probably that patient is going to do good. Therefore, it is also a prognostic marker. BRCA is also a prognostic marker of an improved outcome in ovarian cancer. Similarly, it is also a predictive biomarker, meaning if there is BRCA mutation, these patients can be targeted with a PARP inhibitor. So it is predictive, it is prognostic, both of the things. Now we also saw, since we will be discussing about what to test, it was already discussed also what all we can test. So we have to understand between what is germline and what is a somatic mutation. Let us say someone has a germline mutation. That means this mutation was present in the embryo itself. During the process of zygote formation, the mutations have been there. And now, since it has been there in the zygote, it will be present in the entire cell of all the organism. So in the human being, if there is a germline mutation, you will find across this mutation in all the cells of the body, including the ovary, the saliva, the blood. That is why we go for germline testing. When we go for germline testing, we go for blood or saliva testing to know, because all the cells will have this deleterious mutation. Somatic testing is, and of course, since this germline mutation, it is there since birth and during zygote formation, it can faithfully be transmitted, because that will also be present in the gametes, and therefore it can be faithfully transmitted to the progeny. something known as a somatic mutation. Somatic means it was acquired somewhere during in the tumor, let us say. So suppose someone has a somatic mutation, that means in the tissue itself, in the tumor tissue itself, the mutation was there, and because of this, the mutation will be found only in the tumor. It will not be present in the gametes, and of course somatic mutation cannot be, if it is only a somatic mutation, it cannot be transmitted to the progeny. So this is how we test. So when we go for somatic mutation testing, we go for tissue, and when we go for germline mutation testing, we go for the blood or the saliva. Now with this, why do we need to test? This slide was again discussed. We need to test because, as I said, BRCA testing, because BRCA is predictive. The mutations in BRCA, it is predictive for response to PARP inhibitor. We would like that our patients would have an improved outcome in ovarian cancer. So by that reason and by that logic, we go for testing. And what we understand, as was discussed, high-grade serous ovarian cancers, 50% of them have some or the other defect in the homologous repair genes. And mind you, all these 50% of the patients are eligible for the PARP inhibitor therapy, which have really revolutionized the treatment outcomes in ovarian cancers, as we'll shortly discuss. So any problem is okay? So approximately 50% of the high-grade serous ovarian cancers have alteration in the homologous recombination repair genes, and these can be either, as was discussed, BRCA, germline, or somatic, or it can be promoter methylation. Also, other genes like CDK, RAD51, FA gene, all of these things can be part of the homologous recombination repair pathway. So these are the genetic drivers, which was shown again in epithelial ovarian cancer. The major chunk we saw BRCA1, BRCA2, but of course there are many other which are there in the homologous recombination repair pathway. So if such is the case, in which patients should we go for testing of these BRCA and homologous recombination deficiency? So if you go for that, although high-grade serous is the paradigm for BRCA testing, because it is the most common histology associated with germline BRCA1-2 mutation. But such mutations have been identified in all epithelial histologies. That meaning we can find such BRCA mutations in the endometrioid type, in the clear cell types. So other than the mucinous, most of the subtypes have some sort of this homologous recombination repair pathway defect. Therefore, we usually recommend that for all patients who are having these tumors of any histology, if they are in advanced stage where the role of PARP inhibitor is there, we should go for testing. And we can go for germline testing or somatic testing. There is always a debate first. Why I personally prefer germline testing, it is because there are some familial implications. If there's a germline which is mutated, then there is an implication for the family. That is why if germline is negative, we go for somatic testing. Second reason why we go for germline is that in our setup, in our country, the germline testing is much more validated compared to the somatic HRD testing. Somatic HRD testing is something which is new, which has been validated in the West in appropriately taken studies and diagnostic kits. But in our country, we are slowly picking up with the somatic, that is HRD testing. This slide was again discussed. So one thing which we saw here was that we can find the spectrum of mutations across variety of malignancies. And we usually go for DNA, this BRCA repair pathway testing, the HRR pathway testing, especially in the high-grade serous or endometrioid histology. Now, coming to the BRCA mutation, that is the basic pathway. So again, we have discussed that what is a homologous recombination repair and what is a homologous recombination deficiency. See, when we go for testing in ovarian cancer, we usually go for either germline BRCA or the somatic BRCA or the homologous recombination deficiency or HRD. We don't do routinely HRR gene panel in ovarian cancer. HRR gene panel is rather done in the prostate cancers. So what is the HRD and HRR? You can just remember the cause and effect. So if there is a defect in the HRR gene panel pathway, you will get HRD. And what is HRD? It is homologous recombination deficiency, and therefore there is genomic instability. And this homologous recombination deficiency, how to categorize or calculate it in a form of a score, because the clinical trials which have included these HRD for testing for PARP inhibitor, they designed it in such a manner that we get a score of HRD. So that's a quantity, they have provided a quantity or value to the homologous recombination. They have quantified the homologous recombination deficiency, and that was known as the Myriad My Choice Companion Diagnostic Test, which was used in these clinical trials. And this HRD will actually take into consideration three things, that is the loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. We are not going to details of this. We just understand when we say that we are having an HRD score of more than equal to 42, we mean that we have taken into consideration these three parameters and we have found out that the score is 42. So according to the clinical trials, if someone has an HRD score more than equal to 42, is eligible for the PARP inhibitor therapy, right? So with this background of germline testing, BRCA testing of somatic, and HRD and HRR understanding, we now come to how do the PARP inhibitors work. So the concept was synthetic lethality. So what is a synthetic lethality? Basically a cell which has functional BRCA. On the left side, you can see, let us say this is the normal, that is the normal cell. In the normal cell, we have a functional BRCA. So we know that BRCA repairs what? It repairs double-stranded DNA. So suppose there is a single-stranded DNA break, it could be repaired by the PARP enzyme. And once the single-stranded PARP enzyme repairs the DNA, it's done. The cell, the DNA is repaired and no further damage. However, if in a normal cell, that is the functional BRCA, that is in the normal cell, if you go for PARP inhibitors and you inhibit the PARP, do you think anything will happen to the cell? No, nothing will happen. Why? Because the BRCA is unmutated here. So even if there are generation of double-stranded DNA breaks, the BRCA will be able to repair it, and therefore the cell will survive. Now come to the next scenario in the tumor cell when there is a dysfunctional BRCA. So what will happen here? So already you are inhibiting the PARP. So there will be single-stranded DNA breaks which cannot be repaired. Ultimately, they will be transformed into double-stranded DNA breaks. Now, what is responsible for repair of double-stranded DNA breaks? It is the BRCA. Now, does this have a normal BRCA allele here? No, the BRCA is mutated. So what will happen? So the accumulation of large amount of double-stranded DNA breaks ultimately leading to collapse of the replication fork and therefore the cell death. So this is known as synthetic lethality. Basically, in BRCA deficient cells, PARP is the Achilles heel. That means in BRCA deficient cell, the PARP is the pathway which is responsible for DNA repair. And if you can synthesize something to inhibit the PARP, you induce a synthetic lethality. So you are synthesizing the lethality in BRCA deficient cells by inhibition of the PARP inhibitors. So that is why this is known as synthetic lethality. Anything else which can also cause synthetic lethality in BRCA mutated cells? Yes, the platinum compounds, because they have their mechanism of damage of DNA, they cause DNA damage of both the DNA strands, and the platinum compounds, they can also induce synthetic lethality in the double-stranded DNA break in the BRCA deficient cells, although they don't inhibit PARP, because they generate such a large amount of double-stranded DNA breaks and intercalated DNAs. The defective BRCA doesn't have the capacity to repair so much of DNA damage caused by cisplatin or platinum, and therefore synthetic lethality is also induced by these agents. So this is the concept of synthetic lethality. So what did we say? We said that if single-stranded DNA breaks are not repaired, they will be converted to double-stranded breaks. If both the PARP, that is the inhibitor by PARP inhibitor, and the BRCA repair enzymes, that is BRCA mutations, are insufficient, that means they are deleterious mutations in the BRCA and simultaneously you are inhibiting the PARP, then the DNA damage may become irreversible and result in apoptosis or synthetic lethality. Platinum agents also induce interstrand cross-linking, is not adequately repaired by the homologous recombination deficient cells, leading to cell death through mitotic catastrophe or apoptosis. So we should remember that the BRCA mutated cells are highly sensitive to platinum. Just going to simplify things. Now see here on the left-hand side, the DNA damage. So there are two pathways in the normal cell. That is pathway A, let us say it is BRCA, which is the main pathway. So the arrow is thicker. The pathway B, it is PARP. Okay, both of them are normally happening in the normal cell, so cell survives. Now, if there is a DNA damage in the cancer cell, so what will happen? So if the pathway A, that is the BRCA, it is deficient, but the pathway B, that is the PARP pathway, it is still active, then it will overcompensate and it will become overactive, and therefore the cell will still survive. So BRCA mutated cells will survive because the Achilles heel, the PARP pathway, is very active in them. Now let us come to the cancer cell when you are inhibiting the pathway B. So we know that the pathway B is the Achilles heel. So in the cancer cell, which is BRCA mutated, and if you go for inhibition of the pathway B, which is very, very overactive in a cancer cell, you can see there is no further repair of any DNA damage, and ultimately the cancer cell dies. Now, this is a concept of synthetic lethality. So with this understanding, we now understand that who should be offered maintenance therapy with PARP inhibitors. So we know that if there are BRCA mutations, these patients will likely be benefited from PARP inhibitors. So what are the ideal patients who should be offered PARP inhibitors? Someone who has a pathogenic germline BRCA1/2 mutation. So if there is germline or somatic BRCA1/2 mutations, or if there is an homologous recombination deficiency as assessed by an adequate test with appropriate cutoff, these are the candidates for PARP inhibitor therapy. Now we come to what are the data which is available for PARP inhibitors. So I showed you the names of some of the PARP inhibitors. Olaparib was the first drug to come. Then there was niraparib. Then there is veliparib. And then there is rucaparib. So these are the four. And then there is also talazoparib. So there are 5 PARP inhibitors. In our country, we have olaparib and rucaparib. We do not have the other 3 PARP inhibitors. So the role of PARP inhibitors has mainly been in the setting of frontline maintenance therapy. Let us just give you a brief of how an ovarian cancer with stage 3, stage 4, which is known as advanced ovarian cancer, the paradigm of high-grade serous, I can tell you, so that you can put into context how we use the PARP inhibitors. So what we do usually is that in an advanced ovarian cancer, usually surgery cannot be done upfront. So we go for some form of a chemotherapy, which is known as neoadjuvant chemotherapy. After 3 cycles of neoadjuvant chemotherapy, we then go for an interval cytoreductive surgery, where the aim is to remove all the visible disease or complete cytoreduction, which is known, and it is done by the surgical oncologist. Now, after completion of cytoreductive surgery, we go for remaining 3 cycles of chemotherapy. So there are total 6 cycles of chemotherapy. And as of now, till few years back, this was the only treatment which we gave. And at the end of the 6 cycles, we stopped because there was no therapy as called as maintenance therapy. So what was the ultimate thing? So whatever benefit you got in advanced ovarian cancers with surgery and chemotherapy, majority of these patients, 70% of the high-grade stage 3-4 ovarian cancers will relapse in a couple of days. By end of 1 year, you would start seeing that patients are having a relapse of their disease. And once the disease relapse, it's beyond the purview of cure, and many patients will die ultimately of intestinal obstruction because there's a lot of peritoneal involvement. So there was an unmet need for maintenance therapy in patients with the high-grade serous endometrioid stage 3-4 ovarian cancer. There was an unmet need. We needed something better rather than to stop therapy. And that is why we got this PARP inhibitors as an agnostic therapy for those who are having a BRCA mutation. And what it has done is that it has tremendously improved the survival outcomes. So basically, you can take into context, suppose we go for the olaparib, the first box, olaparib solo 1 trial. It was given in patients who are having a response to platinum chemotherapy and they are having a germline BRCA. So any of these patients, if at all you are going to go for PARP inhibitor therapy, better go for a testing of germline or somatic or HRD, then only go for PARP inhibitor therapy. So if you go for maintenance PARP inhibitors therapy in such patients, you see the median progression-free survival was 56 months versus 13.8 months, meaning that almost 4 times there has been a progression-free survival benefit. So someone who is not on PARP inhibitor will somehow progress in more than a year. Around 14 months, there is disease progression. But someone who has been on a PARP inhibitor, the progression will happen after 56 months, that is around 4.5 years. So there is tremendous improvement. So this comes at a cost of some of the toxicities like anemia, neutropenia, and nausea. Similarly, if you go for other trials, the olaparib, niraparib, veliparib also, similar sort of results, only some of these trials, they have included the tumor BRCA mutations and HRD, and some of them have taken irrespective of BRCA mutations or HRD. So whether we should go for PARP inhibitor therapy in those who do not have a BRCA mutation, if you go by science, clearly the answers would be no. But somehow, even though those patients who are not having a BRCA mutation and HRD, niraparib has shown some benefit in this patient. But remember, this is not the standard of care. The standard of care is PARP inhibitors being used in those who are having homologous recombination repair deficiency or BRCA mutation. Just see the Kaplan-Meier survival curves, how different they are. So if you don't go, so the red one is without any maintenance. You can see almost by 13 months, 50% of the patients have progressed. And in the olaparib, we have not reached yet the median. Still at 54, 56 years, still 50% of the patients are deriving benefit. So that is the benefit of PARP inhibitor in a BRCA mutant and HRD subset. Rucaparib, again, this was the latest study. And in this rucaparib study, what they have shown, again, as I told you, they have shown that even if someone doesn't have any HRD, that is, if it is not having BRCA mutation or no homologous recombination repair deficiency, still these patients are getting benefit from rucaparib. But if you see the magnitude of benefit, see, someone who has an homologous recombination deficiency present, the median difference is around 16, 17 months. So 11 months with placebo, 29 months with rucaparib. But see, if someone is HRD negative, it's only 3 months. Whether it's a clinically significant, I won't say that. These are costly drugs that are associated with toxicities. So we need to properly and rationally choose these drugs. Someone who does not have an HRD or a BRCA mutation is probably not going to benefit much from PARP inhibitor maintenance therapy. So the question here is, based on these results, should rucaparib be used in patients with advanced ovarian cancer without a BRCA mutation HRD? My answer would be no, because the magnitude is not that great to call it clinically significant. So we saw the patients who are ovarian cancer patients who are put on these PARP inhibitors, they have an improvement in the progression-free survival. So do we see that there is any overall survival benefit? So we want our patients to live longer. So some therapy which makes our patients live longer is probably much better compared to some drug which does not make us live longer, only it helps us in controlling the disease, but doesn't make us live longer. So these are two different concepts, the PFS and OS, that is why it's different. We think that our therapy should improve our survival, but is it happening? Statistically, if you see, it looks like it was a statistically significant improvement in overall survival with olaparib, because the p-value is 0.0004. But mind you, the study was designed as such that we needed a much robust p-value compared to what this is, and therefore this is negative. That means addition of olaparib compared to placebo, although it is a significantly marked improvement in progression-free survival, has not translated into overall survival. Sounds a bit paradoxical, but let us chalk out what the reasons could be. So although this is not statistically significant, so what could be the reasons? You see, many of these patients who were on placebo, once they have progressed, they were put on drugs like olaparib. So if at all you would have continued them on placebo without giving olaparib, probably we would have got a significant result, but it is not ethical. You cannot deny a patient olaparib after progression in the placebo arm. So therefore, that could be one of the reasons, that is post-progression, because there was an improvement in outcome with addition of PARP inhibitor in the placebo arm. Probably that's why we are not seeing a significant difference in overall survival. Second thing is that the data is still immature. We still need more events to see before we can call it as a negative or positive result. But do you not think the graph, the way it looks, the separation as it looks from the 60 months onward, you can see very well that both the graphs are suffering. Don't you think that it is a clinically significant and meaningful benefit? Definitely. Because without maintenance, if you go in the historical perspective, without maintenance therapy, the median 5-year overall survival in BRCA mutated ovarian cancer was approximately 38%. That is at the 5-year survival. I am saying it was 38%. Just see here, the 5-year survival here has been approximately 73%. Don't you think that it is really great? Here we are talking about 7-year survival of 67%. And more importantly, if you see, the BRCA inhibitor therapy is given only for 2 years. How come the patients are going to get benefit at 7 years also? This is known as carryover effect. That means if you are giving for a limited period of time also, the benefit is carried over for a longer period of time. Where else have you seen a carryover effect? We see this with hormonal therapy, that is tamoxifen in breast cancer. We give it for a limited period of time, but the patients keep on deriving benefit for a longer period of time. So even though we are saying that we do not have a very statistically significant overall survival with PARP inhibitors, I feel it is very, very clinically significant and meaningful. Now coming to meta-analysis. So we have seen that there are a lot of studies which were done, 6 or 7 studies. So this is a very interesting meta-analysis which was done by Dr. Seema Gulia and her group and Dr. Sudeep Gupta from Tata Memorial Hospital. And this actually helps us put the PARP inhibitors use in the clinical context. So what do we see here? So intention to treat population, that means all comers, BRCA mutated, unmutated, HRD positive, negative, everyone included. So if you give PARP inhibitors, there is an improvement in outcome. But see the difference between BRCA mutated, HRD positive with BRCA, without BRCA, and HRD negative. Someone who has BRCA mutated, if you add PARP inhibitors, the improvement will be something around 46 months compared to 17.7 months. Someone who has HRD positive, the benefit with PARP inhibitors, that is including BRCA mutated. So you know, if BRCA is mutated anyways, it will be HRD positive, right? So 35 months versus 18 months. If it is, however, HRD positive, so let us say BRCA is unmutated, some other pathways, some other genes in the HRR pathway are mutated. So that is known as HRD positive, excluding BRCA mutation. The benefit comes down now. The margin, the difference has come down. 22 versus 13 months, still significant. However, if HRD negative, that means no BRCA mutation and no HRD, what is the result? 15 months with the progression-free survival with PARP inhibitor versus on 11 months with the placebo. Is this statistically significant? No. So we again go back to the same concept. One thing we see here is that those who are having BRCA mutated, those who are having HRD positive, they should only be offered PARP inhibitor therapy. There has been no benefit consistently, as was seen here in the meta-analysis in HRD negative subset. The other thing which I was trying to tell you was also just see the placebo arm survival, progression-free survival. Someone who is a BRCA mutated, you will have a progression-free survival of 18 months. Even if you don't give any PARP inhibitor, it will be 18 months. Someone who is HRD negative, that is no BRCA mutated, the progression will be 11 months. What does it tell us? It tells us that, as I said, that BRCA can also be a prognostic factor in ovarian cancer, meaning that those patients who are having a BRCA mutation are probably likely to have a better outcomes in terms of progression-free survival compared to those who do not have a BRCA mutation, whether you give PARP inhibitors or not. And if you give PARP inhibitors, their outcomes is going to be excellent. This is exactly what slide decks we have tried to show you. So you can see here in the left-hand side, we have 2 curves. That is the BRCA mutated and the BRCA mutated with HRD, and the HRD positive with BRCA negative. And finally, the last one on the right side is the HRD negative subset of population. So the Kaplan-Meier survival curves almost imperceptibly, they go on side by side. and there is no difference here. But in all the other 3 arms, that is BRCA mutated, HRD positive BRCA mutation, HRD positive BRCA negative, no mutation, we can see that there is a significant improvement in the progression-free survival. So if at all, now we want to put this thing in the clinical practice, how do you go? So as I said, in a classical case, we go for some neoadjuvant therapy. Then we go for an interval debulking surgery. At all points of time, we should try and do the molecular genomic analysis before you are there reaching the timeline for maintenance therapy. That has to be done before itself, whether you are trying at the time of diagnosis or at the surgery. And what test you should be doing? You should be doing either germline BRCA, or you should be somatic BRCA, or the HRD. All the 3 tests, ideally all the 3 should be done, because as you could see, there are some patients who have germline BRCA, some with somatic BRCA, and some with HRD. So all this panel of tests should be done in whatever sequence. And if at all you are having a BRCA mutated, you can see we should go for PARP inhibitors. If the BRCA is wild type, still homologous recombination deficiency is positive, we should go for PARP inhibitors. However, if BRCA wild type and homologous recombination proficient, although niraparib has some data and rucaparib in clinical context, usually we will not use any maintenance therapy, or bevacizumab is what we use in the clinical practice, because as I very clearly showed you, the benefit is not that great. This was something about PARP inhibitors in the frontline setting. Default for patients with by default stage 3-4 ovarian cancer who are getting chemotherapy and have found to have some platinum response should be put on PARP inhibitor if they are having the BRCA mutated or HRD positive. There's no doubt about that. We must remember this. So suppose someone has not been able to get the benefit of PARP inhibitor in the front line. Should we go for PARP inhibitor in the relapse setting? Yes. In the relapse setting also, there is a recommendation for PARP inhibitors, again, in those patients who are having this BRCA mutation and the germline, somatic, or HRD. Based on variety of these studies, you can go for maintenance therapy after platinum sensitive relapse actually. So suppose a platinum sensitive relapse means at least after 6 months of last platinum chemotherapy, if the patient relapses, and you can again re-challenge, and you can re-challenge them with platinum and you get a response, and then you can put them on the PARP inhibitors. So these are the data for that platinum sensitive recurrences, and these are the PFS and OS data as we see. So what is the current status of PARP inhibitors in the recurrent ovarian cancer? So they are FDA approved either as multiple lines of therapy in the platinum sensitive or platinum resistant, or in platinum sensitive therapy after inducing a response by the platinum, you can also put them on the PARP inhibitors. How do you choose between PARP inhibitors and bevacizumab? Best thing to do is that if it is as simple as that, if someone has not received any PARP inhibitor, and if you want to use PARP inhibitor, go for the testing. If it is mutated and HRD positive, go for PARP inhibitor. Suppose someone doesn't have any mutation, HRD is negative, better to go for bevacizumab, which is an anti-angiogenic agent in this setting, and there is data for that also, right? So I think I have concluded my talk on the PARP inhibitors, the BRCA, homologous recombination deficiency, what do we test, synthetic lethality. Now let us try to answer these questions. These are the summary of whatever we have tried to teach you in this session. So we have learned that what is the mode of inheritance with BRCA genes. As I said, it is an autosomal dominant mode of inheritance, although functionally it acts like a recessive gene. What BRCA genes are involved in the repair of single-stranded DNA break or double-stranded DNA break? The answer is double-stranded DNA break. We knew that single-stranded DNA breaks are repaired by the PARP. BRCA is responsible for double-stranded DNA break repair. Synthetic lethality is seen in BRCA deficient cells by PARP inhibitions or platinum salts or both. So we saw that PARP inhibition causes synthetic lethality because that is the Achilles heel in the BRCA deficient cell. Platinum salts, they also cause synthetic lethality in BRCA deficient cells by producing a large number of double-stranded DNA break, which overwhelms the BRCA mutation. Next question, BRCA mutation in ovarian cancer, is it predictive or prognostic or both? The answer would be prognostic as well as predictive. As I said, prognostic because we saw if there is a BRCA mutation, probably this patient is going to do better compared to someone who doesn't have a BRCA mutation. Predictive because if there is a BRCA mutation, it is likely or predicts the response to platinums and predicts the response to PARP inhibitors. Which of the following tests are advised in advanced ovarian cancer for use of PARP inhibitors? As I said, so we basically do either germline or somatic, HRD or HRR. So as I said, HRR is something which is not done in ovarian cancer. We usually go for germline BRCA testing, somatic BRCA testing, and HRD testing. HRR is usually something which is done in prostate cancer. Which of the following patients is least likely to benefit from therapy with PARP inhibitors? This also I would like to take that the take-home message should be very clear that we should be using PARP inhibitors only in those patients who are having a germline BRCA mutation or a somatic BRCA mutation or an HRD positive, because those who do not have any of these are very limited, are unlikely to benefit from the PARP inhibitors. So with that, I would like to conclude. I would like to thank the International Association of Oncology for this opportunity, and thanks a lot, and we'll be coming ahead with a lot of such other programs. Thank you.
Thank you so much, sir. We have a couple of questions, and my
Dr.
Zoom
Sambit is there?
Yeah,
Yes,
I am
yes.
there. So I have a question. Great talk, Sourav. Awesome.
Thank
So it's an
you.
excellent talk. So I have a question. So what is your take on non-serous histology and HRD mutations?
Yeah, so basically, as I said, there have been data, if you go by the previous papers which you have shown, although high-grade serous has a major chance of getting this BRCA mutation and the HRD, even the other histologies like the endometrioid and the clear cell, we should also be doing the mutations in such patients also, except the mucinous. We are doing it in our practice also.
Yeah, because in our data set, what I saw, these are all pure serous.
Pure serous.
These are not the cancers which has a mixed morphology.
I think it would be great to analyze your data on the other histologies. I think there would be a lot of cases like that. That would be really interesting.
Yeah, because whatever we are getting, because we get it from the oncologist, and they are referring mostly because so far I haven't seen a single non-serous where BRCA testing is done, at least in our center. So it would be interesting to see their data. And secondly, within the high-grade serous, every high-grade serous is not alike. They have a little bit of, there are distinct subgroups. One with an infiltrative type, one is a pushing type, and we saw different immunohistochemical signature in 2016 in a paper where we saw serous carcinomas with a little better survival has a different morphology and immunophenotype than the ones which are really bad. So it would be interesting to look at their HRD status in those tumors.
Okay.
Why they are doing well and some are not doing bad. And then the second thing is clear cell is another tumor. These are bad. Clear cell are again bad tumors.
Yeah, exactly. I do agree.
Yeah. And is there any clinical trial or any data on role of PARP inhibitor in clear cell tumors?
I think the clinical trials, as you can see, most of them have been in the high-grade serous and endometrioid. So in fact, we have very limited data, or almost that is a data-free zone, I can say, in clear cell. In fact, in our clinical practice also, we haven't seen that many number of patients. We see a lot of mucinous.
No, clear cell is very, very rare as such. It's a rare tumor.
Yeah.
And also in the carcinosarcomas, that is another area. The carcinosarcomas, that is also another area to be looked after. Whether we do get those kind of things.
HRR, I think if at all we have a high-grade serous or endometrioid component, we should be doing BRCA in those also. Because a lot of this, with the treatment of carcinosarcomas is almost, although they are very bad biology, it's very, very similar to how we treat high-grade ovarian cancers.
Right. So in those tumors, in our subset, there are some carcinosarcomas where we have a epithelial component of high-grade serous and some sarcomatoid differentiation.
And
so,
they're having BRCA mutation as well.
The BRCA2 and ATM. I think we had ATM and BRCA2 in those.
Okay. Okay.
Some I can look at the cases and tell you.
This
but
would be some interesting data actually, to take the data of BRCA in carcinosarcoma in clear cell and all, right?
yeah, and to look into those cases.
Those cases, yes, yes,
Yeah.
definitely. So there are some questions here. So I think both of us can take it. So I think there has been some doubt again about homologous recombination repair, that is HRR gene testing and the HRD testing. So Sambit bhai, what do you think? How would you like to explain that? I mean,
Which one?
we have, yeah, HRR gene testing, gene panel testing, and
Ah.
HRD testing. So the question from the audience is, what is the difference between them?
See, in prostate, typically what we do, we look into the defect. So what
Yes,
all
yes.
genes are mutated, looking at the whole gene on the splice side junction of those
Yes.
11 genes, and we
Yes.
say there is a defect in the homologous recombination repair pathway.
Pathway, yes, yes. But when, yeah, yeah, I think you Dr. Sambit, are you there? We are not able to hear you actually. Hello. Hi, hello. I think.
Hear me?
Yeah,
Am I audible now?
yeah. Now it's audible. Yeah,
Hello.
please. Yeah, audible. Please go
Okay,
ahead.
okay. So HRT, because in ovary it is we get a HRT score because we
Yes.
have all the 4 components to
Yes.
estimate that. But
Exactly.
in HRR, when you look into other tumors, we do not have a score. We can say there is a defect in the pathway, but we do not have a predefined score.
That is exactly what. So basically, HRD is something which has been synthesized. That is a score, and that happens because there is homologous recombination repair deficiency, and that leads. So cause and effect is something which we can remember. If there is deficiency in HRR, we can get something known as HRD, and in ovary there has been a cutoff which has been decided for this HRD or homologous recombination deficiency. I think that answers the question. There are other questions also. Of these are not related. Yeah, so I think we have HRR, HRD. Yeah. Are PARP inhibitors adequately specific that they minimize non-target patient cell damage? Are there any pathway effects resulting in any other side effects? So basically, as we said, the toxicities will be there because the some amount of damage happen in the normal cells also, and therefore we can see toxicity, but it is unlikely the chemotherapy and all, which have very large scale and effect on the normal cells. Here, because we are specifically targeting the BRCA deficient cells, so suppose someone has a BRCA mutation in the germline, so even the normal cells will have a BRCA mutated, that is one copy would be there. So if such cells are exposed to PARP inhibitors, so there will be some sort of toxicities which will happen, but it is not that great or that large as compared to the chemotherapy. But of course, there are some non-target damage also. So very right question in asking this. And so there is one question: are somatic mutations observed along with the progression of metastasis? So we can say, so basically, I think, so Dr. Sambit, what she wants to ask is that, do you think that mutation, what time should you do, whether you should do it upfront or whether you should do it at the time of relapse? So basically, what my understanding is that BRCAs are driver mutation. So mutation, the tumor suppressions in the course of the disease. I don't think you acquire a BRCA mutation.
No.
Yeah. So you'd either have a BRCA mutation and have the disease. So at the time of disease itself or at the time of progression, whatever it is, we can do the mutation and those in any point of time. But at least the concept is that we should do it. That is very important.
We should do it at any point of time, either at the primary presentation or the relapse or recurrence. As you correctly said, these are oncogenic drivers.
Yeah.
So they are present anyway.
Yeah. So I think we have covered most of the question.
There are some more actually in the genes.
Yeah. Is there any repair mechanism available to reduce the ovarian cancer by the help of physiological methods? Any chance to use any other less cost-effective methods to reduce? So as I said, So there is not any pharmacotherapy or any specific thing to stop or to prevent ovarian cancer. So as there are mostly, these are non-modifiable risk factors other than the risk reducing salpingo-oophorectomy in those who are having this high risk penetrant deleterious mutations.
There is another question. What is the main cause of ovarian cancer in a village woman?
Village woman, I think village, I do not know if there is any high incidence of ovarian cancer in villages. So there's no data.
Mostly in the urban areas. It is mostly diseases of the urban and affluent society.
What we can say is that if you go for clinical context, the symptoms due to ovarian cancer are so vague. So most of the patients will therefore present when they have a very, very advanced disease. When there is bowel obstruction, when there is bladder obstruction because of peritoneal disease, most of the patients present because the symptoms of early stage ovarian cancer are very vague, just like dyspepsia, and that could be one of the reasons why patients present very late.
And there's a question on HRD scoring system. We take other genes as well, not the BRCA. The prototype is the BRCA gene. And I think Dr. Harvin Gulati, she is a famous gynae pathologist in Hyderabad for American, and she had some case to share. Harvin, could you unmute and ask and share your experience?
Yeah. Hi, Dr. Harvin, please go ahead. So can we please unmute Dr. Harvin? Organizers?
Yes, sir. Just give me a second.
Yeah, Dr. Harvin Gulati.
Yes.
She can share.
Second, sir.
Is she there or
yes, the thing is, I myself don't have the host access right now, so I'm trying to reach the host so she can help.
Yes, sir. Yes, sir. Please tell me.
Can you unmute Dr. Gulati, Harvin Gulati?
1 minute, sir. I'm just checking on. Harvin Gulati. Sir, he is unmuted, sir. Okay. I'm just making him panelist. I have promoted him. If sir was accepting it, yes. Now he can.
Good evening, sirs. Thank you. Yes. So we recently had a case of low-grade serous carcinoma, sir, which showed germline BRCA mutation, sir. So, we were surprised when we got a mutation, and then, the whole thing started, whether it was high grade and all, then we did P53 and all. So it all came wild type P53, but it did show. So what is your experience, sir? Low-grade serous, sir?
So I don't think I have a Dr. Sambit, you can take it up. I haven't seen BRCAs in low-grade serous. I mean, as such, I haven't seen.
I mean, I have seen but what is the variant allelic frequency Arvind for that case? What is the VAP?
So it was a germline mutation. No, sir, it was a germline mutation. Yes, sir. Yes, sir.
Okay, so it was a germline and low-grade serous.
Yes, sir.
Do you think, Sourav, if it's like an event which is unrelated, maybe? Because if it is a low-grade serous, low-grade serous is not a P53 animal. It is a different tumor. And low-grade tumor doesn't arise through the same pathway.
Same pathway, exactly. That's what.
And if it is a germline mutation, then probably this is something, a bystander mechanism, rather than it is something which is causing the tumor. What is your take on this, Sourav? Did you find anything in the literature, Harvin, in this regard?
Sir, yes, sir. 10%. They have quoted this thing of 10%. Sir, 10% cases of low-grade serous carcinomas can show BRCA mutations. So,
Okay.
and our mutation was a little different, sir. It was a duplication, sir. So
Okay. Oh, it was a
it was.
duplication. Okay.
Yes, sir, duplication. So it was a very rare case scenario, sir. We were like totally Fox tumor board mein bari discussions and all that, sir. It happened. So
because
so it
whether
was,
I mean in such scenario, are you going to treat the patient, Saurabh?
yes, sir. Okay, sir. Yeah, if
Because
this
Saurabh
case
is
is
the
being
right
treated,
person.
sir. Yeah, sir.
What is your take on this kind of cases when you have a HRR deficiency in one of the genes and the patient has a low-grade histology and it is a germline defect? And what is the HRT score? Do you have any idea, or just a
No, sir.
notation of
It was just a germline BRCA panel, sir. BRCA
okay,
oncoline
BRCA
oncomine
panel.
panel.
Okay.
Yes, oncomine panel.
So what is your take on this, Saurabh? Is he around? I think he's. I think he probably.
Yes, so but in this case, we are treating her with carboplatin and paclitaxel combination. It's been 4 months. She's been on that, and she's being just followed up for breast carcinoma. Also, mammogram has been done for that. So till now, there's nothing. But she's from a very affluent, and she had a family history, so that is why they got a BRCA done for that
Yes.
case.
Okay. Germline BRCA. And family
Yes,
history
sir.
of what? Ovarian or breast?
So there was a breast carcinoma in an aunt, and also one colorectal cancer, which is unrelated, in one of the male members.
Okay. So they have a family. There's a BRCA family basically. So in such scenario, um, it is sort of interesting to
So,
see how that low grade, maybe this low grade, I feel that I may be incorrect completely. I feel that low grade is a different tumor,
yeah,
which is
yeah.
unrelated to this pathway. And was there a somatic BRCA also, or just a germline BRCA?
So somatic BRCA would have come positive. So I didn't
Yeah,
get a
it would,
BRCA done.
yeah,
Yeah,
if germline is positive anyway, the somatic.
it would have come positive, but I did a colon panel and I did a KRAS mutation, which was negative in this case. So there's some like FGFR mutation was there in VF was very less in that somatic panel,
Some tumors
but it was
hybrid between the low grade and high grade. Because typically the low grade serous do not transform into a high grade. They are
correct,
different
sir, correct.
tumors.
So actually, sir, on morphology, it was borderline serous. But based on invasive implants in appendix, we called it low grade serous. It was bilateral.
Okay. As per the WHO, you can bump it up to a low grade serous.
Yes. So we had to bump it up. Otherwise, it was morphologically we entirely submitted to ovary. Yeah, it was borderline. Yeah, yes, sir. Low grade serous borderline. So
yeah, this is
that was
interesting case to take follow up and see how the patient is doing.
Yes, sir. We are following it up. So it's been 4 months. So it's coming for they are giving her paclitaxel and carboplatin, not PARP inhibitors, but they are giving her the benefit of
for benefit, at least there is a drug.
Yes, sir.
Yeah.
Yes, sir.
If there is for later on. Great, thank you, organizers. And if there is no more question,
so there was one more thing, sir. Like this HRR panel which you are doing, it is the same as I think we are doing HBOC panel, the hereditary breast and ovarian cancer panel. I think
we
that's
do
the
have
same
HBOC panel, but HRR is different. We do it for prostate and high grade serous ovarian.
Okay. That is different, sir. And so for poly, what are you using, sir?
For which one?
Poly mutation.
Poly, we have actually one NGS. We do not have poly separate.
Yeah. So which panel?
There's an NGS panel. So if getting a request for poly, only we are outsourcing. If we are getting NGS, then doing it together, because we do not have a separate poly to offer. We do it within the NGS panel. A lot of people, they cannot afford, so they ask for only poly. So in that case, we outsource it.
So we are doing it by some other methodology. So, but like we have just started doing poly.
No, we have poly in the 555 gene panel.
Acha, the tumor insight panel.
Ha.
Okay, sir.
Yeah.
Yeah. So thank you, sir. Thank you so much, sir. It's always a pleasure to talk to you, sir, and learn so much from both of you, sir.
Same here. It was great interacting with the audience. All of you are very enthusiastic. And this is something upcoming. And thank you, BioLeaks and IAO, for organizing these sessions. So it's Saturday night. Still, we have so many people, almost 9 o'clock. So have a good weekend, everyone. And thank you, organizers, again for your immense help in organizing this. Really appreciate it.
Thank you, sir. It's always our pleasure. It was so wonderful to see this interaction. I'm sure everybody found it very useful, sir. Thank you so much, sir.
Thank you. Looking forward to have a good weekend. Bye-bye.
Bye, sir. If the participants can just stay for just a couple of minutes, I just have a few announcements to make regarding your certificates. So your certificates will be emailed to you in the next week. And just one more thing. So I'm sure like all of you would have found this webinar really useful. And we have 2 more webinars coming up in the month of February. The one based on head and neck cancer in the Indian context is on 9th February. And the next one is held on 26th February on the topic past, present, and future of lung cancer management. I'm going to leave the link to these webinars in the comments in the chat box, so you can always go back and check it out. So I'll just leave this in the comments, and you will also get details about this when you receive your certificates. So thank you all so much once again for your active participation. It was wonderful to have this discussion in this webinar. Thank you all so much. Have a good night. And you will also be receiving a feedback link. So please fill that out along with your certificate. You'll get it in the email. Thank you so much. Have a good night.